Hello everyone, myself Dr. Veena and I am a dentist and I am currently working as an academician in an institution and also as a consultant prosthodontist at various dental clinics. I have finished my graduation, that is Bachelor of Dental Surgery BDS, and post graduation Masters in Prosthodontics and Crown and Bridge, which basically deals with replacing of missing teeth with caps and bridges, dentures and implants. So currently I am pursuing my PhD and I am working basically on artificial intelligence applications in dentistry. I am creating these videos to share my knowledge and experiences about dentistry with you all. I hope this will help you in clearing all your dental related doubts. So you will find everything about dentistry here. So let's get started. So today I'll be starting with the first topic, which is very important for when you are in first year or second year, that is anatomic landmarks of the mandible. So what is an anatomic landmark? It is a recognizable anatomic structure which is used as a point of reference. So how do you classify anatomic landmarks? They are basically classified as peripheral or limiting areas, supporting or stress bearing areas, and relief areas. So now let us understand what is a peripheral or a limiting area. So these areas are the areas that limit or that define the border extensions of a complete denture. So we can see a maxilla and a mandibular cast, and we can see here how the peripheries have been marked. So these areas are called as the peripheral or the limiting areas. So let us understand which are the limiting areas or peripheral areas in maxilla and in mandible. So maxilla we have labial frenum, same way labial frenum in mandible, labial vestibule, buccal frenum, buccal vestibule, distal extension, that is the maxillary tuberosity, and the posterior palatal seal. Same way in mandible we have labial frenum, labial vestibule, buccal frenum, buccal vestibule, and the most distal extension is retromolar pad, and lingually we have alveolingual sulcus. So let us see what is an labial frenum. So it is a fold of mucous membrane that extends from the mucous lining of the mucous membrane of the lower lip towards the crest of the alveolar ridge. So it is seen here. So what is the importance of this labial frenum? Shorter and wider the mandibular frenum, the labial frenum in mandible is shorter and wider than the maxillary frenum, and you need to provide adequate relief for the muscle activity in this area. So which muscle comes here? That is the mentalis muscle. So you need to allow the proper activity of the mentalis. So you need to relieve the area in the complete denture. So you need to ensure a proper fit around this so that a seal is maintained without causing any soreness to the underlying frenum and the other mucosal structures. So now coming to labial vestibule. So it is a fold of mucous membrane extending from labial frenum to the buccal frenum. We can see here extending from labial frenum, and this is the buccal frenum. This part is called as the labial vestibule, and the corresponding part in an impression is known as labial flange. So now coming to buccal frenum. So buccal frenum, this is the buccal frenum. It can be single or multiple. Which muscle comes here? It is depressor anguli oris that gets inserted into the buccal frenum, and the corresponding area in this is the buccal notch in your impression. So now coming to buccal vestibule. So buccal vestibule is a fold of mucous membrane extends from buccal frenum to the distal end of the retromolar pad. So this is the buccal vestibule, and the corresponding area in your impression is known as the buccal flange. Coming to lingual frenum. So it is a fold of mucous membrane extending from the floor of the mouth to the inner surface of the alveolar ridge. So it may be single, and some cases it will be multiple or absent, but it's very rare that it is multiple or either absent. So coming to alveolingual sulcus. So the alveolingual sulcus extends from the lingual frenum to the retromylohyoid curtain here. So this extends completely the alveolingual sulcus. So we have on the right side and left side. So this complete thing is your alveolingual sulcus. So how do we divide this area? This area is divided into three by mylohyoid muscle as pre-mylohyoid sulcus, mylohyoid sulcus, and the retromylohyoid or a post-mylohyoid sulcus. The pre-mylohyoid means the area or the sulcus that falls before the mylohyoid muscle, and the mylohyoid sulcus which runs from the pre-mylohyoid fossa to the distal end of the mylohyoid ridge. We all know where the mylohyoid ridge is, which is also known as internal oblique ridge. It is present on the inner surface of the body of the mandible. So your mylohyoid sulcus runs from the premolar fossa to the distal end of this mylohyoid ridge. So coming to the retro or post-mylohyoid sulcus. So the flange passes deep into the retromylohyoid fossa distal to the mylohyoid ridge. So the area, the sulcus that lies distal to this mylohyoid ridge is the post-mylohyoid sulcus. So what did we see now? The mylohyoid sulcus divides your alveolingual sulcus into three parts. That is pre-mylohyoid, that is before the mylohyoid muscle. The mylohyoid, okay, that extends till the distal end of your mylohyoid ridge, and the retromylohyoid that comes after the mylohyoid ridge. Now coming to the next important part, that is retromolar pad. So it is a triangular pad of soft tissue elevation that lies distal to your third molar. Suppose, so we can see in the picture here, this is the retromolar pad. This is a triangular pad of soft tissue elevation that lies distal to your third molar comes here. So it lies distal to your third molar. So it is a limiting landmark that will mark the distal extension of your complete denture. So what is its significance? The 2/3 of the retromolar pad determines the height and width of your occlusal plane. So consider this is your retromolar pad. When you divide it into three parts, 1, 2, when you draw two lines, it will divide it into three parts. The middle one, that is the second third or the 2/3, your occlusal plane height corresponds to height of this 2/3 of the retromolar pad. Now let us understand, there is one more terminology called as pear-shaped pad. So let us understand what is the difference between these two. Okay, so retromolar pad is a soft elevation of mucosa that lies distal to the third molar, whereas the area formed by the residual scar of the third molar and retromolar papilla, that is once you extract the third molar, okay, there is a healing. So whatever area is formed by the residual scar including the retromolar papilla will form the pear-shaped pad. That means pear-shaped pad is anterior and retromolar pad lies to this pear-shaped pad. So it's already mentioned here, it lies posterior to the pear-shaped pad. So the mucosa over this retromolar pad is non-stippled and the mucosa is attached, and the gingiva, that is the retromolar papilla, is also stippled. So I think we all understand what is the term by stippling. So now coming to supporting areas. The first supporting area is your residual alveolar ridge. So it is the bone which remains after extraction of your natural tooth. You can say that this entire thing is the residual alveolar ridge, and this is the one that remains that is residual after the extraction of your natural teeth. Coming to buccal shelf. So this is considered as this is the only one primary supporting area in mandible. So it is the area situated in the posterior part of the mandibular denture foundation on the buccal side. We can see here, this is your mandibular ridge, and on the distal side on the buccal surface lies the buccal shelf area. So anteriorly it is bound by the buccal frenum, as we can see here, and posteriorly by the retromolar pad, and medially by the crest of the alveolar ridge, and laterally by the external oblique ridge, and inferiorly by the base of the bone. And the same thing when it is marked on the cast and when you see it in an impression. So as I already mentioned, it is a primary stress bearing area. Why primary stress bearing area? Because it contains a thick compact bone, so that can absorb more stresses, and the forces, the occlusal forces or say masticatory forces, are perpendicular to this area. So the forces are better absorbed. So you can take a complete support from this area for your mandibular denture. So now coming to the next, we now studied about the supporting areas. Now we will come to relief area. So we studied our limiting areas as well as the supporting areas. Now coming to relief areas. What are those relief areas? To list them: mental foramen, genial tubercle, mylohyoid ridge, mandibular tori, sharp bony spicules that are present over the alveolar ridge, and a knife edge ridge. Mental foramen. So it lies between your first and your second premolar. First and second premolar, somewhere between these two premolars. Okay. Due to ridge resorption, it may be closer to the crest of the ridge. Suppose when we extract all these teeth, and as the bone resorbs, as the height of the bone goes down, so you can see the mental foramen comes closer to your crest of the ridge. So whenever you make a denture, if the foramen comes under the denture, so whenever there is more forces, or when you press the denture over that area, so it will cause injury, or say it will cause tingling sensation or numbness, because in the foramen we have our mental nerves and vessels. So it is mentioned here that it should be relieved, as pressure over the nerve passing through it can be compressed by the denture base, leading to paresthesia of the lower lip. Why lower lip? Because the mental nerves and vessels pass through there, which supply your lower lip. So now coming to the next one, that is genial tubercle. So it is an area of muscle attachment for the muscles, that is genioglossus and geniohyoid, and they are present over the lingual side of your mandibular bone. So as we can see in the picture, so here we have a pair of genial tubercles to which we have two muscles being attached, that is genioglossus and geniohyoid. So initially it lies away from the crest of the bridge. It is prominent in resorb ridges, as already I mentioned, the same with the mental foramen. So here also same thing happens when you extract the teeth. As the bone resorbs, that is the height of the bone reduces, these will come closer to the crest of the ridge, and when they are pressed by a border of your denture base, so that will cause soreness, because these are the sharp points, and the mucosa over that gets pressed against these sharp points, and it will create soreness and pain for the overlying mucosa. So you need to provide adequate relief in this area. So now let us see another relief area, that is your mylohyoid ridge. So it is the attachment, this entire thing is your mylohyoid ridge, which is also known as internal oblique ridge, and it is the attachment for your mylohyoid muscle. So this mylohyoid ridge is sharp or irregular shaped, and it is covered by the mucous membrane. So trauma from the denture base to this, since this is sharp, after the resorption this becomes more prominent. So whenever there is like pressure from the overlying denture, so the mucosa over this sharp bony ridge will get traumatized. So you need to relieve this area. So whichever these bony structures I am mentioning, no, so because of the resorption, they become more prominent in like elderly patients, in old age patients. So you need to palpate them during your case history taking, and see that you relieve all of them to prevent discomfort for the patient. Now coming to mandibular tori. It is an exostosis found on the lingual surface of the mandible opposite to carines and premolar region. So these are the bony masses, and in mandibular they are usually found in relation to your premolars and canine region. If they are small and non-prominent, you can only give a relief under the denture. If they are larger and prominent, you need to excise surgically. So now we are coming to the end of our anatomic landmarks of mandible. So in this picture we can just summarize here. So we have limiting structures, that is labial frenum, buccal frenum, labial sulcus, buccal sulcus, okay, and the distal limiting structure is your pear-shaped pad here, sorry, the retromolar pad here, and then lingually we have lingual sulcus, also known as alveolingual sulcus. Okay, and this is your lingual frenum. So coming to your supporting areas, so the buccal shelf is the primary supporting areas. Okay, other areas like slopes of your ridges, posterior alveolar ridge, they will form your secondary supporting areas. Okay, and we also mentioned some relief areas like your genial tubercles on lingual surface, mental foramen somewhere here, and if at all present any tori or any sharp bony ridge. After the resorption, the crest of the ridge becomes sharp. So at that time you need to provide relief in that area also to prevent the discomfort for the patient. So I hope this will help the students. Thank you everyone.